I've had such. Now, hang on. Something catastrophic has happened. Can you still see my slides? Yeah, okay. So thank you very much indeed for inviting me. I've had such wonderful fun with Turkish hospitality that I can't wait to come back again and have some fun, all of us together. So I've got no conflict of interest for this presentation. I'm first of all going to discuss the clinical approach to a child referred with preschool wheeze, which is refractory to treatment. Sorry, I've got some allergic rhinitis, but I'm going to try to give an understanding of the possible treatment options and how we're starting to personalize therapy in a practical way, but we still have a very long way to go. And I'm also hope to show you some of the novel approaches to future treatment and also prevention and some of the successes and failures, but also to remind us that preschool wheeze is not just something transient, but it signals a lifetime risk of COPD and premature respiratory, cardiovascular, and metabolic deaths. So first things first, the clinical approach. And for me, it's useful to think of coughs and wheezes under 5 headings. The first is normal child, and that's the hardest diagnosis. People always laugh when I say I work at the Brompton because it's easy. It is easy because by the time they get to me, they're all ill. The second category is serious illness. For example, CF, TB, it's rare, but it's important to get right. And the common differential diagnoses will vary depending on what part of the world you're in. Here you can see with a child with flat diaphragms, a lot of airway wall thickening. This was in the days before CF screening, and this boy had pancreatic sufficient CF and was in the asthma clinic. One of the asthma syndromes, which I'll discuss. There may be minor problems such as rhinitis or reflux, which may mimic or exacerbate wheezing symptoms, and the over-anxious, often first-time parents. We all know all that wheezes is not asthma, and we need to take a good history and carry out a detailed physical examination. And we've made big mistakes, at least in my country. Isolated chronic dry cough with no wheeze and no breathlessness in an otherwise well child is rarely, if ever, due to asthma. And certainly in England, we have overdiagnosed and overtreated cough variant asthma. That it exists, I don't doubt, but it is a lot rarer than people think. And some of these children, most of them, will in fact need no investigations at all. You'll make all your therapeutic decisions appropriately on the basis of your history and examination. And certainly the testing of these children, it should be targeted. And importantly, what are the range of normal respiratory childhood symptoms? Well, normal cough, we've all seen a child who's had bronchiolitis or a respiratory viral infection with a prolonged cough. People don't realize viral colds, 10% of children may have at least 10 colds a year and symptoms for at least 2 weeks. And children may have 3 or more attacks of otitis media a year. We've seen a lot of pertussis and parapertussis, pertussis particularly, as people have been reluctant for foolish reasons to immunize their children. And nursery school syndrome, it's usually a first child, early placement in a childcare facility. They get, as you all know, repeated viral infections with one viral cold merging into another. And of course, it doesn't respond to antibiotics, bronchodilators, steroids, or anything like that. And the treatment for this is a hot lemon and honey drink for the child and a glass of wine for the mother, both to be repeated as often as possible. And particularly for the trainees, I would strongly recommend you get out this meta-analysis from the British Medical Journal. It's a meta-analysis of the range of normal childhood symptoms, respiratory symptoms, what you can expect a normal child to suffer in the way of colds and etc. And you cannot possibly determine what is abnormal until you've got a thorough knowledge of what is normal. So in the history, obviously we take a focused history. Is it really wheeze? And we increasingly use a video questionnaire because in my country, at least, intelligent parents will use many different will use wheeze to describe many different sounds. Crackly noises, upper airway noises. Is it really wheeze? Do they have prominent upper airway symptoms? Do they snore? Have they got adenotonsillar hypertrophy? This one's important. If an experienced mother tells you the child has had symptoms from the first day of life, that is not asthma. That needs to be investigated. It's completely different from a child who at 3 weeks of age gets a cold from their older brother who's at school. Very sudden onset of symptoms.
E poi con delle misure profilattiche che però di fatto
Chronic
non hanno
moist
mai
cough.
aiutato più di tanto. E puntualmente la sospensione.
Competing. Oh yeah, you've done it. Well done, Billy. So if a child with chronic wet cough, a child with 4, 6, 8 weeks of chronic wet cough every day, that child needs to be investigated. And the child who's worse after meals, whose arches off the breast or from the bottle, irritable, vomiting, think reflux. Obviously, look for evidence of systemic illness or immunodeficiency. And the child with continuous unremitting symptoms. And this is what I mean. This is actually, I stole this diagram from a paper on TB, but it makes important points. The child who's got a burst of symptoms with a cold gets completely better, another burst of symptoms, that's almost certainly normal. You see this prolonged post-bronchiolitic cough, and again, you've seen this before, but the child is gradually getting better. You can afford to wait. It's this child with relentlessly worsening symptoms that you want to be concerned about. What about the physical examination? Well, obviously look for clubbing, weight loss, failure to thrive. And I'm afraid certainly in England, we are very bad at looking for clubbing. Pediatricians don't seem to do it. And a couple of times a year, we'll see a child with fingers like this that clearly the clubbing didn't develop overnight. Look for upper airway disease, tonsils, particularly nasal polyps. And you can see an example here. There's a nasal polyp sticking out of the nostril. And if you see a nasal polyp, think cystic fibrosis. The child with the unusually severe chest deformity, it may be due to asthma, but it probably isn't. And if there are abnormal auscultatory signs, a fixed monophonic wheeze, stridor, or asymmetric signs. And of course, you'll be looking for evidence of cardiac or systemic disease. And always think the foreign body. Very sudden onset of symptoms. The mother who said that my child was fine until Tuesday a week ago and has coughed and wheezed since. Always ask, could this child have choked or aspirated? Because they may not volunteer the history. Listen for abnormal signs, but the signs may be bilateral or absent. The chest X-ray may be normal, and if the history is good, that child gets a bronchoscopy. And the world record, as I'm aware of, is Duncan Geddes, my adult colleague, who pulled out a baro top, a thick baro top out of the airway of a 32-year-old man, who said, oh, it's interesting. I swallowed that when I was 7 years old. And because he thought he swallowed it, everybody assumed he'd come out in the feces. Sometimes, as here, I'm sure you all spotted that tooth in the right main bronchus. I mean, no amount of inhaled steroids is going to cure that. So what about treatments? And at the moment, we are often stuck in pattern recognition in the 20th century. So 2008, this was the European Respiratory Society Task Force, published in the ERJ. Has been cited more than 1,000 times. And we're at that stage to find episodic viral wheeze as a child who wheezed only with clinically diagnosed respiratory infection. It's not the same as transient wheeze. It may persist into the school years. The multiple trigger wheezer, by contrast, wheezes with viral respiratory tract infections, but also between infections with excitement and allergens. It may persist, but it may not. It's a guide to current treatment. That's what the aim of it was, that if you had intermittent symptoms, you would give intermittent treatment. It was not a guide to prognosis, and we accepted that the pattern of symptoms may change over time and with treatment. But, and here's the but, it relies on parental symptom perception. Do the parents notice interval symptoms? And there's no connection to endotype. No connection at all. What are the pathological processes? What are the molecular pathways causing this problem. The next step, 2012, an update of these guidelines. Again, there was a recognition that patterns change over time and with treatment. And again, suggested that inhaled corticosteroids might be appropriate for multiple trigger wheeze, but also suggested considering them for recurrent or severe episodic viral wheeze, particularly if underreporting of interval symptoms is suspected. All treatments are still an N of 1. Try it and see if it works. And again, still no connection to endotypes. So if episodic viral wheeze is not steroid responsive, just because it's severe is no reason to be giving them steroids. So let's think, that's where we were, and I'm going to show you in a few slides' time where I think we are now and where we should be going. But let's look on that basis, the indications for treatment. Well, you might want to stop disease progression to school-age asthma with inhaled steroids. You might want to treat symptoms, and I'm going to deal with these in turn. So inhaled corticosteroids, we all thought, and we know, that inhaled steroids are a fantastic treatment for school-age eosinophilic allergic asthma. We know that. So it seems logical, if they're such good treatment for asthma, let's start them before the asthma develops and they won't get asthma. Totally logical, totally wrong. So these are two studies, PEAK and IFWIN, the Manchester study, both of them treated very early wheeze with inhaled corticosteroids and failed to prevent progression to asthma. The PEAK study on the top panel, you note the 0 is suppressed here. Red is the placebo-treated patients, blue is the fluticasone-treated, a small treatment benefit. But after 2 years, when the treatment is stopped, the disease comes back. And this is Hans Bisgaard's study. This was intermittent inhaled steroids at the time of a viral wheeze. Again, no difference. And just to be aware, that my slides seem to have come to the ground to a halt. Sorry, but my slides seem to have frozen. Here we go. Right. Just to be aware that obviously if the child needs inhaled steroids, they should get them. But this is the Manchester study, and this looks at airway resistance in 2 groups of patients, those who never had fluticasone and those who had a single course of fluticasone. And you can see at follow-up, those who were treated with fluticasone had airflow obstruction. So steroids are not something to be given out like Smarties. So what about the role of inhaled steroids? This was Mike Silverman's study, as usual, 25 years ahead of his time. Continuous inhaled budesonide failed to prevent viral exacerbations of wheeze in preschool children. Small study, absolutely seminal. There are a number of studies for the United States. They use nebulized budesonide because that's the only steroid that they are allowed to use by the Food and Drug Administration. And they showed that intermittent montelukast or intermittent nebulized budesonide were better than standard therapy. This is Francine Duchamp's study. This enormous dose of fluticasone, 1.5 milligrams a day with viral colds, reduced prednisolone requirement. But I absolutely do not think that dose is safe. And here another American study, nebulized budesonide intermittently versus nebulized budesonide continuously were equally effective or ineffective in preventing symptoms. Unfortunately, there was no placebo group. What about montelukast? Well, cystinyl leukotrienes are raised acutely with preschool viral wheeze, and parents will probably not medicate well children. So the PREEMPT study, led by Cole Robertson in Melbourne, looked at intermittent montelukast versus placebo in 220 children. And they showed giving montelukast intermittently was superior to placebo. You've seen these data already, intermittent montelukast better than placebo from the USA. But this huge study, nearly 1,800 patients, looked at placebo versus intermittent montelukast versus daily montelukast, and showed no difference in the primary endpoint. There were some subtle differences in the secondary endpoint. In the primary endpoint, no difference, trial fails. And this is Jonathan Griggs' weight study, nearly 1,400 patients. Again, intermittent Montelukast, no benefit. Perhaps a suggestion that a pharmacogenomic approach looking at particular ALOX mutations may delineate a subgroup in whom it works. But overall, the two big studies with over 3,000 patients in them, no benefit. So at best, Montelukast is a minority medication. Most children will not respond. And this, I'm sure you recognize this famous picture, the scream. And I'm putting it in to remind ourselves that there's a prevalence of about 20% of psychiatric and behavioral symptoms on the Montelukast. You need to warn the families and be ready to stop it. So having said that, of course, I should also say that one of my grandsons was treated by Montelukast by the GP, and he got completely better from his symptoms and had no side effects. So there are some who respond, but by and large, it is not a safe and not a good medication. So the suggestion is that you have episodic treatment for episodic problems. First of all, does the child need treatment at all? Just because the child's not making noises, is the child distressed? It's no easy task giving a child a mask and spacer. I next go to intermittent or continuous leukotriene receptor antagonists, but don't anticipate much benefit. The next is high-dose inhaled corticosteroids. I would not go above 150 micrograms twice a day of beclomethasone, and I would monitor carefully. And the counsel of despair is combinations of the above. What about multiple trigger wheeze? Well, I would propose to you a 3-step trial. Step 1 is to commence treatment with a high dose of beclomethasone, 200 micrograms twice a day for 6 weeks via a spacer. And see the child after 6 weeks. Is the child symptomatically improved? If not, think of alternative diagnoses. This is not a steroid-sensitive disease. If the child is improved, key next step is to stop the treatment, because you don't know if the child's improved because you're a very clever doctor, or because the child was going to get better anyway of their own accord. And if the symptoms recur on stopping treatment, if they don't problem solve, if they do recur, then you titrate restart beclomethasone and titrate the dose to the lowest needed to control symptoms. And if you use this, you will avoid you giving a treatment for a transient symptom and making a false diagnosis of asthma. What about macrolides? Well, we all know that macrolides cure every disease known to pediatrics. They have multiple anti-inflammatory and antiviral effects. And in this COPSAC study, 158 asthma-like episodes, and I don't know what that means, lasting at least 3 days, they showed that azithromycin shortened the duration of symptoms, provided it was given early on in the illness. This is a Len Beccaria's North American study, 600-odd children. They had to have had at least one course of steroids to get into the study, and they were randomized to either azithromycin or placebo, and the azithromycin group seemed to get less steroids. By contrast, this study, published in the emergency department from PLOS One, showed no benefit of macrolides. So what's their role? I would suggest to you that they may be worth trying in those with acute, really severe wheeze, those who end up in HDU or PICU. But if every child who gets a bit of cough and wheeze with a cold is treated with a macrolide, as sure as God made little apples, pretty soon there will be macrolide resistance rife in the community. What about prednisolone for acute preschool wheeze? And this is another area where this is different from adult asthma. So nearly over 1,700 children aged less than 6 years in 11 studies, and they looked at overall admissions, outpatient studies, and emergency department studies. And panel A, hospital admissions, you can see there's absolutely no effect of giving prednisolone. Actually, in outpatient studies, those that got steroids were more likely to be admitted. A suggestion that in the emergency department, they may be beneficial. If you take all comers, giving steroids doesn't seem to be beneficial, but if you're an inpatient, perhaps if you get in with steroids early, you reduce the subsequent requirement for steroids. So there's panel D, no reduction in extra steroids. There's panel E, may reduce the need for more steroids. And overall, most children do not benefit with preschool wheeze, do not benefit from oral steroids. Certainly, if they're not being admitted to hospital, they absolutely do not need oral steroids. There's a hint that there may be some benefit in the sicker patients, so the really sick ones in hospital, yes. And maybe this is a non-genomic effect of steroids, for example, reducing airway edema. I've said this before, but I'd like also to show you two other studies. This was a study in the Lancet Respiratory Medicine in the emergency department. They said if you give them prednisolone, it saves 117 minutes in hospital. P equals 0.0227. And Jonathan Griggs' study, bigger study, coincidentally exactly the same 117 minutes, saving of time, not significant. I've put to you that really these data show actually this is not a community care medication, not even routine in hospital, but possibly a multi-trigger wheezer with severe exacerbation or any severe wheezer heading for the PICU. We've also got to focus on smoking, and to smoking I would add vaping. And I know ALIF has been very active trying to combat, and many others have been active trying to combat the evil effects of the tobacco smoke. So this is Ben Nemery's data from Flanders, and they looked at the different pieces of legislation. As time went by, they tightened up where you could smoke. There was fewer and fewer places, and they looked at nearly 500,000 spontaneous deliveries to see how the outcome was preterm birth less than 37 weeks. And you can see each time there was new smoking legislation, preterm birth fell. So legislation works, and we must campaign on behalf of our children. So we've talked about pattern recognition, and really in the 21st century, we should do better. So let's try what has been done for phenotype-based treatment. And this is Sejal Saglani's work, bronchoalveolar lavage in really severe wheezers, viral wheezers, persistent wheezers, and you can see that there's no difference between the two of them. The clinical description does not distinguish between the two. Some had high eosinophils, some did not. And if you look at atopic and non-atopic wheezers, you can see some of the atopic wheezers had eosinophils, but many did not. And I would put to you that now the time has come for this clinical classification to be confined to the dustbin. We've got to do better for our children than that. So how do we go about it? And this is taken from the Lancet Commission, which I had the honor of co-chairing the INPA board. Deconstruct the airway. What is going, rather than use labels, is it asthma, doctor? What's actually going on in the airway? So does the child have fixed or variable airflow obstruction? Specifically bronchoconstriction, but you can have unstable airways from loss of these lovely guy ropes. Do they have the concept of a treatable tray? Do they have something that is treatable? Do they have bronchodilator responsiveness? If so, prescribe beta-2 agonists. What about airway inflammation? Is it present or not? What's the cell type? Is it beneficial? What's the pathway? But the important thing, do they have airway eosinophilia, the treatable tray of that? And if so, steroids may help. Finally, if they have airway infection and impaired host defenses, think about antibiotics. Now, this is not new or novel. The late, very great Freddie Hargreaves was doing this for many years before his sad death. But deconstruct the airway, what's going on, and how can we do this in practice? Well, this is the infant study, and it's a really good study. This is in secondary care. These are quite severe wheezers, 300 children at step 2 from 18 USA sites. They were given in random order, daily steroids versus daily leukotriene receptor antagonists versus as needed steroids and salbutamol. Three-way crossover study, blinded, and they had a composite outcome of asthma control days and time to an attack requiring steroids. And they pre-specified they would look at aeroallergen sensitization, gender, and wheeze attacks to see if they could predict the response to steroids. Most importantly, they did not pre-specify the blood eosinophil count. So this is what they showed. They were able to analyze 230 children, 60 of them got better, 170 did not. And you can see that the cumulative exacerbation probability is best in those who are on daily steroids, worse on leukotriene receptor antagonists, and intermittent steroids was in between. And they then did their pre-specified analysis, and you can see here that it's those with aeroallergen sensitization who seem to respond. They then went on post hoc. So this is hypothesis generating. It needs to be validated. They looked at blood eosinophil count, and they had a cut point of 300 cells per microliter of eosinophils. And you can see if you had a low blood eosinophil count, it didn't matter at all what treatment you got. If you had a high blood eosinophil count, you did much better if you were given daily inhaled steroids. And they post hoc again combined aeroallergen and blood eosinophil count. And you can see that the 64 patients who were aeroallergen sensitized and had a raised blood eosinophil count, they were the ones that responded. So for the first time, we have two practical biomarkers, accessible biomarkers, whereby we can start to personalize treatment in the clinic, rather than get stuck in sterile arguments about whether we give steroids to everybody or nobody, or at what age can we diagnose asthma. Some confirmatory work, we looked at induced sputum and bronchoalveolar lavage and blood eosinophils, and there was a very good correlation in this small group of severe patients between BAL and blood eosinophils. Interesting, you can see here that blood on the vertical axis, BAL on the horizontal axis, both raised, both normal. There's really good concordance. And some wheezers, here you can see some had raised BAL eosinophils, but many did not. Interestingly, unlike older children with asthma, the younger children with asthma, with preschool wheeze, there was very poor correlation between sputum and BAL. If you're looking for infection, you can do induced sputum, even in children as young as a year, and it's probably at least as good as BAL. As I've said, induced sputum is a poor marker of airway eosinophilia. I would say that if you have no blood eosinophilia, it's likely there's none in BAL. But blood eosinophilia may be driven by other atopic diseases. And of course, in parts of the world where parasites are endemic, it may well be that eosinophilia is related to parasites. So we need more data. And we talk about phenotypes like the cellular phenotype, sputum eosinophilia. Let me just one word of caution. So what is a phenotype? It's a set of observable characteristics of an individual resulting from the interaction of its genotype with the environment. So remember the time domain, because if the environment changes, the phenotype may change. So what do I mean? So here's a 10-year-old atopic boy. He's got untreated wheeze. He's allergic. He's got airway eosinophilia. Somebody gives him inhaled steroids. He takes them, and the inflammation vanishes. He's pauci-inflammatory. He's got no inflammation. He then gets a huge allergen load from cats and gets eosinophilic again, despite his steroids. He then gets a viral cold after the allergens have gone, and he's now neutrophilic. He stops taking his inhaled steroids, as children do, and he becomes eosinophilic, and then he restarts them and becomes pauci-inflammatory. So the phenotype flips to and fro, depending on the environment, including adherence. And these are Louise Fleming's data from her MD thesis. 55 severe asthmatics studied over a year, 42 had at least 2 samples. 10 of the 42 were always eosinophilic over the year. 29% were always non-eosinophilic, but nearly half flipped to and fro. And the same is true in mild and moderate asthma. And you can see here the top panel, the sputum eosinophil count, bottom panel sputum neutrophil count, they are all over the place. So we've got to remember the time domain. And what we need to know is what is the molecular pathway. So the boy I showed you in the previous slide, the molecular pathway isn't going to change. We've got to find out what it is. So now I'd like to take us beyond the eosinophil. Are bacteria the bad guys? Now, when I was a medical student, wheezing was all about viruses. Viruses triggered wheezes. Bacteria were nothing to do with it. Bacteria caused pneumonia, but that was the extent of it. And then came this classic paper from Hans Buskard's group. He took his COPSAT cohort, 321 neonates, and at a month of age, he did hypopharyngeal swab samples. And nearly a fifth of them were colonized with one or more of strep pneumonia, Moraxella catarrhotis, or Haemophilus influenza. Those 3, but not Staph aureus, predicted later wheeze. So in this panel, you can see the risk of the first wheezy episode. The dotted line, those colonized as neonates. The solid line not colonized, and the solid line is worse. Here you see the risk of persistent wheeze, worse if you weren't colonized. Here you see the risk of hospitalization for wheeze, worse if you were not colonized. Now, what is not clear to me here is whether it's the bacteria driving this, or the bacteria are a marker of some sort of subtle mucosal immunopathology that is driving colonization and driving wheeze. We just don't know. And subsequent to this paper, I'm not going to show you the data. Hans has published the data showing other respiratory outcomes are improved in those who had early colonization. So I'd now like to show you data that Polly Robinson in our group put together. And we had 21 multiple trigger wheezers and 14 episodic wheezers. They were clinically classified on this history. We used the wheeze video to make sure they really were describing wheeze. And they had a questionnaire, blood eosinophil count and sensitization. They had a bronchoscopy and lavage, viral PCR, bacterial culture, and 16S amplicon signaling sequencing to do the microbiota. Now remember, these were bronchoscoped at the time of clinical stability. This was an elective procedure, and the anaesthetist and consultant anaesthetist determined that they were at their baseline state. And 60% had either or both of viral or bacterial culture. That's a whopping amount. The commonest bacteria were strep pneumonia, Moraxella, Staph aureus, and Haemophilus. And rhino, bocavirus, and adenovirus were seen. So we looked at the microbiota, and we found 2 profiles. A mixed profile of strep, Prevotella, Neisseria, Porphyromonas, and these are the sorts of bacteria that you see in the healthy adult airway microbiome. And we also saw a Moraxella group. And you can see here in this analysis, there is a clear-cut separation between the Moraxella group and the mixed or healthy microbiome group. And interestingly, the Moraxella group had increased lavage neutrophils, suggesting this is a genuine infection and not just a bit of contamination. And you can see here on the left, the BAL neutrophils are elevated in Moraxella, but blood neutrophil counts are the same. And interestingly, the wheeze phenotype, episodic viral wheeze or multiple trigger wheeze, did not distinguish between the 2. Although Moraxella tended to associate with episodic viral, it was not clear cut. and atopic status failed to distinguish between the two. Again, a marker that we've got to go beyond the standard biomarkers in the future. And co-occurrence data suggested there was bacterial dysbiosis with Moraxella. I'd now like to take you to some data also put together by Polly Robinson from our group, including Sejal Saglani and others. And this is now just published online in the Blue Journal. So summarizing, there's a lot of confusion in preschool wheeze. We know from Sejal Saglani's data that at the age of 1 year, that preschool wheezers, even those with atopy and bronchodilator responsiveness, are not inflamed, they're normal. By 2.5, the changes of asthma, remodeling, eosinophilia are there. BAL at 1 year, normal increased total leukocytes, it's conflicting. Angelo Barbato's data, BDR responsive wheeze aged 2 to 10 years, looked like eosinophilic asthma irrespective of atopic status. In this study, 13 years old, young wheezers had neutrophilic BAL. So the hypotheses of this data were that the pattern of lower airway inflammation and bacterial and viral infection would differ between those with and without recurrent severe wheeze. Amongst wheezers would be different between multiple trigger and episodic viral wheezers, and would be influenced by atopic status and inhaled corticosteroid prescription. So the methods, 136 children, of whom 105 had recurrent severe wheeze, 31 had non-wheeze respiratory disorders. We had peripheral blood tests and looked for allergic sensitization. They underwent bronchoscopy and lavage with bacterial culture and a multiplex PCR to viruses and mycoplasma. And Adnan Kustovic did some very complex statistical modeling to try to determine were there any clusters in these groups of patients. So the results, we found that interestingly, 28 of 105 patients, nearly a third, could not be classified as episodic viral or multiple trigger wheeze, showing the weakness of this classification. And we found 8 variables to determine clusters: blood and BAL neutrophils and eosinophils, atopy, a positive viral PCR, a positive bacterial culture, or a steroid prescription. And we found 4 different clusters, and there was no relationship of these clusters to clinical phenotypes. So there was an atopic cluster, a non-atopic low infection rate, high inhaled steroid use cluster, a non-atopic high infection rate cluster, and a non-atopic low infection rate, no steroids cluster. 4 different clusters. So cluster 1, all of them were sensitized, all had a high blood eosinophil count, a lot of inhaled steroids, but even this group had quite a substantial burden of infection. The second cluster had low BAL neutrophils, but they also detected bacteria and viruses. All of these had prescribed steroids. Cluster 3 was the most infected cluster of all, and that with the highest bronchoalveolar lavage neutrophils, and 2/3 used inhaled steroids. Cluster 4 were mostly the persistent coughers, not wheezers, no inhaled steroid use, most were non-atopic with persistent cough, not wheeze. And what separated them out? Well, blood eosinophil count, you can see, was separated out cluster 1. Bowel neutrophil count was also different between the clusters. Atopy, viral PCR, bacterial culture, and inhaled steroid use, but not, interestingly, blood neutrophil or BAL eosinophils. Now, whether inhaled steroids modified the effect of BAL eosinophils, I don't know. So what does this mean? Clearly, first of all, this is a highly selected group. They're really severe wheeze, they've failed therapy, they've been referred to a specialist center. And we need to validate this if we can in a second cohort. It's unknown whether any prior inhaled steroid treatment could have affected this. We don't know, importantly, the stability of phenotypes over time. We can't re-bronchoscope them 3 months later. But I would put to you that the 60% prevalence of infection is turning the spotlight firmly on infection, at least some children. And I asked myself, could some of this be iatrogenic? Steroids we know are immunosuppressive and they can cause mucosal immune suppression. So we don't know. Are bacteria driving wheeze? Are they a marker of mucosal immunopathology? Is there a group with susceptibility, for example, to Moraxella? There's a lot more work to be done. And this is theoretical kite flying. It needs to be validated, but implications for treatment. The highly atopic and eosinophilic group, they are the ones who are going to respond to inhaled steroids. They may need antibiotics as well. They may even be a group for type 2 biologics, omalizumab or mepolizumab. Cluster 2, not much in the way of neutrophils or infection. Maybe they would benefit from muscarinic agents. Cluster 3, no atopy, high burden of infection, maybe targeted antibiotics and reduce the inhaled steroids. And cluster 4, which did include 20% of severe wheezers, there was no sensitization, no infection or inflammation. Maybe these would also be muscarinic targets. Now, as I say, this is speculative. These data are pretty hot off the press. They're online, but this is what we found. So that is where I want to leave phenotyping, but I also want hints at maybe future approaches. And that's something can be done, is shown by this study. Genetically very similar people, the Amish and the Hutterites fled Europe to avoid religious persecution. They went to the States. The Amish continued to use traditional farming methods, the Hutterites the most modern methods. And you can see here that genetically they're pretty close to identical populations. And what they showed was that the Amish population had much lower prevalence of asthma and atopy. There was much more lipopolysaccharide in the environment and different microbiological exposures in the dust. And you can see here the endotoxin levels much, much higher in the Amish homes. And they did further in human studies. The Hutterites had more blood eosinophils. The Amish were neutrophilic. Amish monocytes had a suppressive phenotype. And it was innate but not adaptive cytokines that were higher in the Amish children. Hutterite dust-treated mice had more airway eosinophilia, but Amish dust favorably modulated the eosinophilic inflammation, and all BAL cytokines were suppressed by the Amish dust. And this, if you didn't have an innate immune system, the effect was lost. And multiple genes in this volcano plot, you can see multiple genes up and down regulated in between these two populations. Again, for me, pointing the finger at bacteria, at bacterial diversity within the environment. Other things have been tried very briefly. This is olive oil and this is a fish. And this was a study from Copenhagen when pregnant women were randomized either to fish oil or olive oil daily. And the code was not broken for 3 years. 96% 3-year follow-up, brilliant achievement. And the primary endpoint was persistent wheeze or asthma. And the risk of persistent wheeze was reduced by fish oil supplementation in pregnancy. It's not the hugest effect, but there's certainly an effect. The effect was greater in genetic subgroups and those who started with low levels of fatty acids. What about vitamin D? Vitamin D cures everything, doesn't it? So this is our last no. This is the VDART study now, 6-year follow-up, pregnancy supplementation with vitamin D. At age 3, there was a small beneficial effect. And when they did a meta-analysis combining it with another non-significant Danish study, it became significant. Was this an effect on antiviral immunity? But by age 6, no difference. You don't have to be Einstein to work out that both those studies are negative at age 6. So finally, coming on to the future risk and what is the future risk? So the first thing to say, the strongest predictor of going on to school age asthma is severe wheeze attacks in the preschool years with one or more positive skin prick tests with tobacco exposure by age 3. And there is the ROC. You can see how strongly these three things, bad wheeze, the skin prick tests, and smoking and pregnancy, how strongly they predict a high-risk subgroup. Let's remind ourselves of the developmental course of lung function. And here there's the Global Lung Initiative data, nearly 100,000 records, constructed predictive equations for spirometry, which you can see here, to a plateau at age 20. They have ethnic normal values. We could debate that, whether that's appropriate at another time. And what they showed, the key stages, what happens antenatally, what happens as the child develops, and what causes the child an accelerated rate of deterioration. And the roads to COPD, route 1, this is Jürgen Vespo's study, route 1, if you attained a normal FEV1 baseline, then your risk of COPD was 7% with a fast rate of decline. But route 2, if you never got to your baseline, 26% got COPD with a normal rate of decline, and the rates of decline were unexplained, with no consistent effect of smoking. But these data are pointing the finger firmly into the early years, and those with apparently trivial lung function defects and wheezing do badly later on. So this is the Melbourne cohort, again, just age 50, 76% retention, and at age 50, they rephenotyped them into no asthma, current asthma, remitted asthma, or COPD, defined by GOLD criteria, and they tracked lung function back to age 10. And what you can see, the red line, those with COPD already had impaired lung function but at the age of 10. And in fact, what drove the diversion, the difference here is something that happened antenatally in the preschool years. And the odds ratio for COPD with severe asthma is 32. This is the ECFS study, 13,000 plus patients. Risk factors were maternal asthma, paternal childhood asthma, maternal smoking, respiratory infections. The more of these you had, and you'll recognize these factors as predicting preschool wheeze, the worse your lung function, whether you smoked or not. You had lower lung function, no catch-up, a faster rate of decline, and more COPD. Early life events, this early life wheeze is something that is telling you there's trouble ahead. And these are fascinating data. This is Tucson data, 1,400 participants. And in their third decade of life, they looked at mortality and they looked at terciles of FEV1. 122 of these patients died. And if you look, those with the lowest tercile of lung function had a significantly increased probability of dying. And for every 10% decrease in baseline FEV1 percent predicted, this was associated with an increased risk of all-cause mortality of 15% in the third decade. Now, I can see no biologically plausible reason why losing 100 or 200 mils of FEV1 should cause you to die. And this was taken, and we come back to that in a moment. Low birth weight in adults as well. So this is a coal miner, and it's a Welsh coal miner, and you can see he's got a canary in his bird cage. And the canary went down with him down the mine, not because he loved birds or he loved singing, but if the canary stopped singing, it meant the canary was dead, and dead of carbon monoxide poisoning. So the miner would run up to the surface so he didn't die too. And I think FEV1 is the canary in the mine signaling trouble. And here's one mechanism. Here, why would clinically trivial lung function loss be associated with greater adult mortality? Well, we know that low birth weight is the determinant of lung function. and 15% of birth weight variability is genetic in origin. And the genes that determine birth weight are also genes for cardiovascular risk, diabetes, glucose, triglycerides, blood pressure. They're the same genes. And so the low FEV1 is telling us something important about the whole system, not just the lungs. And another study, this is a meta-analysis, 18,000 plus subjects from 22 cohorts. They looked at DNA methylation, epigenetic changes on peripheral blood, which of course I accept is not the same as the airway. And they linked 3 loci of methylation significantly to prenatal and adult smoke exposure. And you can see them here. Model 1 is just the mother smoked. Model 2 is if the mother smoked and her child in adult life also smoked. And all these loci are significantly related to adult smoking and have robust links to cardiometabolic risk factors. So summary and conclusions, where does this take us? The take-home summary, well, preschool wheeze fits into 5 groups. And you're coming back and anchoring us, history and physical examination is initially used for that classification. Preschool wheeze, however, is an umbrella term for complex clinical clusters. We have to get a measurement culture into our bloodstreams. It's not good enough to sit there asking the mother, well, does your child wheeze when they don't have a cold? We can do some phenotyping, and certainly for those with more than trivial diseases, we should be thinking about looking for sensitization and looking for blood eosinophil count. And if we've got patients with acute attacks, atopic sensitization, and tobacco exposure, these are a high-risk group for school-age asthma, but also for COPD and for cardiometabolic mortality. And our goal has got to be to determine endotypes, molecular pathways, and use these endotypes to do randomized controlled trials. So I'd like to end by thanking you for listening, thanking the funders and my colleagues who've done much of the work, especially the children and their families. And thank you very much for listening. I'd like to leave you with my 6 grandchildren on the happy days when we could actually all get together at Christmas. So thank you very much. Elif, I don't know how many grandchildren you've got. I'm up to 6. I suspect I'm still a little bit ahead of you. Thank you very much for your attention. I'm very happy to take questions.
And thank you very much. This again, an excellent talk as I was expecting, and inspiring, and also we gained insight for the current look at especially for phenotypes, which is, I think, very interesting in the future. Yes, yes, Fazilet.
Thank you very much, Andy. It was a great talk as always, very inspiring. My question, I was wondering, why did you suggest beclometasone dipropionate for the first line as a first line treatment? Why did you choose that medication?
To be honest, Fazilet, because it's the cheapest. And I mean, I don't have any. There's no decent comparator study. What I would say, I slightly worry about the more potent new topical steroids, because if you look at the adult data, they show that if you're an adult with COPD using inhaled steroids, you get more pneumonia. There's an association in adults between inhaled steroid use and TB and atypical mycobacterial infection. And I worry that the really potent topical steroids may cause suppression of the airway immune function. Now, of course, if the child needs inhaled steroids, all of us know they are absolutely life-transforming, they should have them. But I think there's a little note of caution that I feel about them. But having said that, as far as I am aware, there's no comparative data between fluticasone, budesonide, beclometasone, and it's quite legitimate to use any of the 3.
My concern was, side effects. Did you not suggest these beclometasone and fluticasone for children for over 4 and 5 years old? And I was just
yeah, it's difficult. I think there may be slightly more side effects. I mean, I have to be honest, at low dose, I don't really see much in the way of side effects. Certainly, if I was in an older child, if I'm needing a higher dose of inhaled steroids, I would not use high dose beclomethasone for exactly the reason you've highlighted. And those I would use combinations like fluticasone, salmeterol, or budesonide and formoterol.
Thank you. Thank you very much.
Yeah.
Nice to see you.
You can ask your questions via chat, or also I have two questions from Dr. Shiva from Oman. He is asking the role of pheno. Is there any role of nitric oxide? And also another topic, but maybe it will be interesting to hear from your answer from you. What is the role of budesonide in COVID? Is there a role for budesonide?
Okay, so first of all, the role of pheno in preschool children, there are very little data in the clinic. You would obviously have to do an offline tidal volume collection. We are about to embark on a study testing this, whether pheno or blood eosinophil count or sensitization or what are the most important things. And certainly pheno is certainly the weakness of the infant study was no pheno measurements. So at the moment in preschool children, we still don't know. It may well be a marker of an atopic eosinophilic phenotype that will respond to inhaled steroids. In terms of COVID and inhaled steroids, the key message is if you have asthma and are prescribed inhaled steroids, keep taking them. Do not stop them because of fears of COVID. There is perhaps some evidence that they may be slightly protective, but I wouldn't say my message would be if you prescribe them for your asthma or you prescribe them to a child for asthma, keep them going in the COVID season.
Thank you very much. And is there any question? And also, I'm happy that we have again participants from 15 countries, including
Fantastic.
Kyrgyzstan, Saudi Arabia, Egypt, Libya, Chile, United States, and European countries, and also especially participants from Italy. I am also thanking my friend Renato Cutrera, and also Dr. Fernando De Benedictis is among the participants as well, and also Peter Ponek is again among the participants.
So it's lovely to know that some very, very old friends indeed, not just from Turkey, but from Italy, from Prague. Lovely to know that they're on the call. And I'm very much hoping that we will drink a glass of good wine together in the not too distant future.
Yeah, I hope so as well. So if there is no question, maybe we can stop the lecture here. Really, on behalf of the Turkish Pediatric Pulmonology Society, we are thankful to you, Professor Andy Bush, and you're always with us and hope to host you in Bosphorus.
Well, thank you very much for having me, and I've really enjoyed giving the talk.